It's a pleasure to be here this morning. The topic I'm covering is understanding anticoagulant therapy. And what I plan to do is give you highlights about how blood clots form and how the currently available anticoagulants work. Now, despite my best intentions, there's a lot of information on the slides. I hope to walk you through this information, but please feel free to take notes, ask questions. So we're going to start with some definitions. Coagulation is simply the process by which blood forms clots. It can be described in much more complicated manners. It's the process of stopping blood loss from a damaged vessel, wherein a damaged blood vessel wall is covered by a platelet and fibrin-containing clot to stop bleeding. Associated words include hemorrhage, which is quite simply not enough coagulation or excessive bleeding, or thrombosis, which is too much coagulation, or coagulation in the wrong place at the wrong time. Now, this is a picture of a blood vessel, and normally blood flows quickly through the vessels. The platelets and the blood clotting factors do not interact with the blood vessel wall because they are not able to interact with the blood vessel wall. They're sort of quiet. They're turned off. In order for a clot to form, there has to be some sort of mechanism that activates the platelets and the clotting factors. These mechanisms can be a cut, such as a surgical cut in a blood vessel, or trauma from falls. Often, things that interfere with the smoothness of the blood vessel lining cells, such as atherosclerotic plaques, can trigger activation of the platelets and the clotting factors. So the key factors that are required are the blood vessel wall, and you can see that up in the corner up here, tissue factor and collagen are two factors that are usually not exposed in the surface of the blood vessel wall. When you damage the blood vessel wall, the tissue factor gets exposed, and that activates one of the clotting factors. The collagen that also gets exposed binds the platelets and activates the platelets. And that starts a series of reactions that ultimately end up in activating thrombin, which is a big enzyme molecule that is important in cleaving fibrinogen to fibrin. So again, the clotting factors and platelets float around in the blood in an inactive state, and that's why you're not always clotting. They need to be turned on to form a blood clot. Now, this is a picture, very enlarged electron micrograph of a blood clot. This is approximately 1,000-fold magnification of what a clot looks like in a blood vessel. And I point this out for a number of reasons. The little red disc-like frisbee-looking things are red blood cells. If you can make out, there are some pink things that are platelets that are trapped in there. But the real reason I want to show this picture is because of the white strandy stuff that looks like mesh. That's actually fibrin mesh. And that's what happens. Fibrinogen gets cleaved by thrombin, and then the fibrin gets cross-linked by another enzyme to make this mesh. I often refer to this as a cargo net type structure that holds the platelets in place and holds the red blood cells in place to close the hole in the blood vessel wall. Now, there are a lot of coagulation factors, and the body has both pro-clotting factors and anti-clotting factors that are listed here. There are a lot of factors on the pro-clotting side that form the coagulation cascade, and I'm going to review that a bit in a little detail. Most of these factors are enzymes or proteins that, when active, they cause chemical changes in other proteins. And again, a trigger has to activate these proteins so that they can then do their job. Again, they run around in an inactive state. Now, the body has a balance. You always have pro-clotting factors and anti-clotting factors, and they're always working with each other to sort of balance, keep you in a balanced state so that you're not always clotting and you're not always anti-clotting. But there are many individual factors that affect what your clotting factors are doing. And those individual factors can tip the scales or tip the balance in favor of clotting or in favor of bleeding. Many of these factors can be genetic, such as inherited blood clotting disorders, such as factor V Leiden mutation, prothrombin gene mutation. You can also inherit genetic disorders that make you bleed, hemophilia A, von Willebrand disease. Many other environmental factors will also tip the scale towards clotting, such as having pneumonia and being in the hospital, having a mechanical valve which presents an artificial surface for platelets to stick to, breaking your leg and being in a cast. Variety of different factors add up for each individual patient to tip the scale in one direction or the other. Now, this is a simplified picture of the clotting cascade. I was once told by a hematologist who's now retired to never show the clotting cascade picture because it puts her audience to sleep. And my husband looked at this last night after being out of town and he said, "Oh my God, what is this? I don't know what this is." He's not in medicine. So I'm going to very briefly try to explain this because I think a lot of people hear about the clotting cascade. There are pictures on the web. The web is a great resource. Wikipedia has a different version of the clotting cascade. But basically, all of the clotting factors that we have, the major clotting factors, were identified in the 1940s, 1950s. They were given Roman numerals, and they're all proteins. And they were given Roman numerals based on their molecular weights and not how they factor in the clotting cascade. And then in the 1960s, someone came up with the thought that these are a series of cascading enzymatic reactions, one leading to the next, that ultimately ends up at the bottom at a fibrin clot. And so that's where the cascade sort of concept came from the 1960s. So these boxes with the Roman numerals represent proteins that float around in an inactive state. They have to be activated, and that's what some of these red lines show. So that factor VII, when it's activated, I'm missing a line here, tissue factor will activate Roman numeral 7, and that will activate 8. That then leads to 10 and 5, activating 2, which is also known as prothrombin. Prothrombin gets converted to thrombin by this 10-5 complex, and then thrombin cleaves fibrinogen to fibrin, which again makes that mesh network of protein strands that causes the fibrin clot. There's not going to be a test on this. You won't have to remember this. If you have more questions, I'm going to show this diagram again, but if you walk out of here and don't remember it, that's completely fine. This strikes terror in the hearts of medical students when we show it to them. So for anticoagulation, the goal is usually to prevent blood clots from forming. Anticoagulants do not thin the blood. Now, I've actually had very astute clinicians tell my family members, well, your blood thinner will do this. They actually technically don't thin the blood. They just make it take longer to form a blood clot. They work by preventing or inhibiting activation of the clotting factors, or if you're on an antiplatelet drug, activation of platelets. Now, a big key characteristic or big key point that I want to drive home is that anticoagulants do not dissolve blood clots. They prevent the existing clots from getting bigger, but other mechanisms in your body actually have to dissolve the clots. So who needs anticoagulant therapy? The top 4 patient diagnoses are the main reasons in the world that people require anticoagulation. And the heart rhythm abnormality, atrial fibrillation, is the #1 reason worldwide why people need anticoagulation. Atrial fibrillation can promote development of clots because there are pockets in the heart when the heart is fibrillating that the blood sits there and it's not flowing quickly. And as it sits still, that actually allows the factors to gather together and form a clot. Deep vein thrombosis, or blood clot in a big vein, is another reason to require anticoagulation. Pulmonary embolus, or blood clot in the lung, and mechanical heart valves. There are also situations with very high risk for developing clots, that patients will be on anticoagulation in a prophylactic or preventative measure, such as after hip replacement surgery or joint replacement surgery, or if you have, say, a very high-risk inherited clotting disorder in a high-risk setting. So often we can look at anticoagulation in some patients as a very careful tightrope between procoagulant and pro-clotting mechanisms causing a clot and the anticoagulation medications causing bleeding. And for a very small subset of people, it really is a tightrope and it's a careful balance between bleeding and clotting. But for the majority of people, it's actually not a tightrope. It's more like a bridge or a plank. And there's actually a little bit of leeway in terms of, if you're a little bit too high, that's fine. If you're a little bit too low, that's fine. So you're not necessarily going to be attacked by a shark and get a clot or eaten by piranhas and bleed. Now, I'm going to take a few minutes to review the current anticoagulant drugs that are used in a variety of different situations. And I'm using the word old because we are all hearing about the new oral anticoagulants. So I'm going to call the early or the first ones to be developed the old ones. These anticoagulants are unfractionated heparin and warfarin. They were developed many years ago, but they're still in great use today. Unfractionated heparin was actually isolated in 1922, went through a series of work in laboratories, and finally in 1937, a method of purifying heparin was developed, and it actually started to be used in humans. So the use of unfractionated heparin dates back to 1937. Warfarin was identified in the 1930s and was finally approved for use in humans to prevent blood clots in 1954. So the question becomes, we have these two drugs, why develop new anticoagulants? The doses of both heparin and warfarin vary significantly from person to person based on individual metabolism factors. The factors do not have to do with weight, they have to do with patients' individual enzyme makeup. Blood tests are needed when we use these drugs to be done to make sure that patients are getting the right amount of anticoagulation, that they're not getting too much anticoagulation and at risk for bleeding, and not getting too little and at risk for clotting. There are really no good ways that we have, and many people have tried to develop prediction nomograms or dosing nomograms. There are no good ways to predict what dose of anticoagulant of unfractionated heparin or warfarin a patient will need. There really is a bit of trial and error. You start at a standard dose, and then you test the blood, and you adjust the dose up and down based on the results. So blood tests are needed to be checked to determine the level of anticoagulation. So in between the old unfractionated heparin and warfarin and the new, the low molecular weight heparins were developed in the early and mid-1990s. Low molecular weight heparins are derived from the old unfractionated heparin. And heparin is a big sugar molecule that has a high molecular weight. And in the laboratory, lots of research by drug companies found that if you isolated the smaller molecular weights of heparin, called the low molecular weight heparin, that there was much more predictability in the dose from patient to patient. So you could give a lot of patients the same dose, and they would have the same reaction and the same level of anticoagulation to that dose compared to the unfractionated heparin. So these were a big advantage in terms of what was available at that time. Many of you may have been on Lovenox if you developed a blood clot. That was approved for use in 1993. Fragmin or dalteparin was approved in 1999. And another medication called fondaparinux, similar to low molecular weight heparins, but different because it's not derived from heparin, became available in 2001. Now, the new anticoagulants that I think everybody has probably heard about, seen ads for on TV, picked up pamphlets from our vendors upstairs, have been recently FDA approved and have developed a lot of excitement about their use. The goal in developing these new drugs, which are developed drugs in pill form that use one strength for most people without the need for any blood testing. One of the first to be available in the United States is Pradaxa, or dabigatran or dabigatran, which was FDA approved in 2010 for use in atrial fibrillation. Another drug, similar new oral anticoagulant, is Xarelto, or rivaroxaban, which was approved for use in 2011, both for treating atrial fibrillation to prevent blood clots and to prevent blood clots in patients who are having hip and knee replacement surgeries. There are many others that are currently being studied or that are actually waiting right now for FDA approval. So moving on from the types of anticoagulants, we have the question of how do they work. All of the anticoagulants except warfarin work by getting into the blood and stopping or inhibiting an activated clotting factor from working. They prevent the next step in the clotting cascade. All except warfarin work within a few hours of taking them. So unfractionated heparin technically needs to bind to antithrombin that then allows it to bind to thrombin and inhibit thrombin in factor 10, is usually administered intravenously and works immediately once it's administered through an IV. Again, the required dose varies from person to person. You need to check blood tests, the PTT, or partial thromboplastin time, to make sure the patient's on the right dose. You can also use the unfractionated heparin as an injection under the skin. There's less variability in this, but still many clinicians will check blood levels in patients getting it injected that way. Low molecular weight heparin and fondaparinux are delivered only by injection under the skin. They too enter the blood and bind to antithrombin before they can work. The antithrombin heparin complex binds to the thrombin in 10A, again to prevent those blood clotting factors from working. There is less or no real individual variations in metabolism with these low molecular weight heparins, so you can give a dose based on weight and expect similar results for the most part from person to person with no need to check blood tests. Again, this is a picture of our favorite coagulation cascade, and you can see that low molecular weight heparin works primarily on factor 10 and factor 2 or prothrombin, and unfractionated heparin works in a variety of the other factors, but most strongly works on factor 2 and factor 10. Now, the new oral anticoagulants, which I discussed, dabigatran or dabigatran and rivaroxaban, are pills that are swallowed and the drug enters the blood. These are a little different. They bind directly to the activated clotting factor and prevent the clotting factor from working. Pradaxa binds to thrombin, and it's often referred to as a direct thrombin inhibitor. Xarelto binds to 10, factor 10A, which is activated factor 10, and it is known as a direct factor 10A inhibitor. Again, when you inhibit thrombin and inhibit 10A, you cannot cleave fibrinogen to fibrin, so you cannot form that nice cargo mesh type structure that keeps the clot in place in the blood vessel. And again, we have dabigatran working on prothrombin and thrombin, and we have rivaroxaban working on directly on factor 10A. Apixaban is another direct factor 10A inhibitor that is currently under review for approval by the FDA. So now we're going to move on to warfarin, which still 95% of the world who requires chronic anticoagulation, patients will be on warfarin. Warfarin has different mechanism of action from these other drugs that I've mentioned. It affects the production of some of the coagulation factors. The pills are swallowed, the drug enters the blood and travels to the liver. The liver makes the clotting factors, so most of those clotting factors in the clotting cascade are made in the liver. The warfarin works to allow the liver to make the clotting factors, but they're not quite finished, so that they cannot be activated by the enzyme that activates them. This enzyme is technically known as vitamin K epoxide reductase, and the factors that are affected by warfarin are factor 2, which is prothrombin, thrombin, factor 7, factor 9, factor 10, and the anti-clotting factors protein S and protein C. Now, unlike the other medications which you take, either the new oral pills or the injectable anticoagulants, which work within hours of taking them, it takes a number of days to get the full anticoagulant effect of warfarin. And it actually can take 4 to 6 days to get the full effect of anticoagulation. So if you're diagnosed with a deep vein thrombosis or a pulmonary embolus, you need another more rapidly acting anticoagulant, and you need to take that before warfarin kicks in. The dose to get the same level of anticoagulation from person to person varies significantly with warfarin. And that's why we need to frequently test patients, because they're a unique makeup that everybody has in terms of how their body metabolizes warfarin. Many factors can interfere or affect with how warfarin works in the liver. The patient education guidebook that is available upstairs on the Brigham and Women's anticoagulation table, in which I think many of you have, goes through a lot of the factors that affect warfarin metabolism. Diet, in terms of how much vitamin K is in your diet, alcohol, antibiotics, and other medications that can directly interfere with how warfarin works. Again, the picture of our clotting cascade. This is the last time I'll show this. Warfarin affects the activity level by preventing production of factor 2 or prothrombin, factor 7, factor 10, and factor 9. So in summary, despite many years of research, many advances, and many new drugs, there is no one perfect anticoagulant available right now that can be used for everyone. Many factors affect which anticoagulant is right for you. You should discuss questions about your specific anticoagulant medication with your medical team, including your primary care physician, cardiologist, hematologist, and anticoagulation management service clinician. Thank you.
Now, I thought, as a cardiologist, when I saw the coagulation cascade gene, I froze. I froze as a medical student when I looked at it. But nonetheless, the warfarin is one of the most used drugs. What don't we do well with warfarin, the physician or the people? What do you think is the biggest deficit in terms of using that?
Well, I think that it's actually been great from my perspective, again, from a hematologist who's been studying the coagulation cascade for a long time. Great to bring it to the public. And that actually what has happened in the last 5 to 10 years is that the public, hospitals, pharmacists have all become much more aware of how to use warfarin. And part of that awareness is the fact that everybody is here in this room this morning. I'm going to assume that most of you are on warfarin. I think it takes an understanding of the fact that there are individual variations in that we need to actually test patients very rigorously in the beginning to make sure that we find the right dose. But one of the other big factors is actually educating both patients and clinicians that there are a lot of different things that can perturb the system, so to speak, and that any subtle or significant change in your lifestyle or other medications will affect what your warfarin level is and your level of anticoagulation in your blood. So, we have practitioners who can tell, it's been Memorial Day weekend and someone gets their INR tested on Monday morning and it's a little high, And they'll jokingly say, well, how many beers did you have over the weekend? We know it was a long weekend. And sometimes people will confess, yeah, more than I usually have. And sometimes it's something as simple as that. So patient education, patient awareness, but also clinician awareness as to what's going on with the individual patient.
May I also encourage the audience to ask questions. We have a microphone, so please step up to the mic, speak up loudly so we can hear you, and we'll try to answer your questions and do so. While people are getting up, Gene, let me ask you also. You had a list of the entities in which warfarin was used, like heart valves and DVT and so forth. The first on your list was atrial fibrillation. And it seems that the medical community is not totally devoted to one form of therapy. A number of patients with atrial fibrillation are treated with aspirin, which scares me a little bit. But what's the rationale for aspirin? And are aspirin and warfarin equal in efficacy?
This could be a very long answer. The aspirin works to affect how platelets function, and warfarin, as I've shown you, affects the clotting factors. And when you look at an individual patient, again, I'm a hematologist, not a cardiologist, there are a number of, say, risk prediction scores for patients with atrial fibrillation in terms of how high someone's risk is for developing a thromboembolic stroke. So there are a number of factors that assess just how strong someone's risk is. As you know, there's a big controversy right now as to whether aspirin is sufficient for some patients at lower risk. And I'm not sure that the dust has completely settled on that. I think there are a number of studies that show that aspirin is insufficient for most patients with more than one risk factor for getting a stroke from atrial fibrillation. There's some new emerging data in terms of aspirin and preventing blood clots, or doing what we call secondary prevention of blood clots, which has actually surprised a lot of us in the field, but I think that data is very immature right now and still needs further development.
Let me ask you one more question. You mentioned in your earlier slides that for a clot to form, there has to be some kind of damage within the vessel wall. Can you get a clot sitting in front of the computer for 8 hours? And what's the damage of that? Because without trauma.
Right. So actually I have a patient who argues just that he sits in one chair in one position, and it's a unique chair. So again, multiple environmental risk factors can affect your risk for blood clotting. And as you know, stasis or blood pooling can actually impact your risk without damage to the blood vessel wall, usually in people who may have other risks that increase their risk for clotting. As I think everybody's aware, long air travel may increase your risk simply because you're sitting still, and when you're in a bent position, it's more difficult for the blood to get out of your legs and back to your heart, so it pools. And when anything's sort of still, I don't want to use the word stagnant, but that allows more time for the clotting factors to interact and to bind. So patients who are at bed rest for 3 days or more without moving are at increased risk for getting blood clots. Patients who have casts on their legs plus other factors are at risk for getting a blood clot in the casted leg. Often it's a combination of factors, such as sitting in one position in front of your computer, plus having a low an inherited blood clotting disorder that puts you at some increased risk, perhaps obesity. Obesity is an independent risk factor for developing blood clots, smoking, inflammation, being ill, being in bed with pneumonia, All of those things contribute to increasing your risk for clots. That's a great question. What warfarin does is when it enters your body, it travels, it ends up in the liver preferentially because it binds to some of the factors in there, in the liver, some of the enzymes. But then it gets metabolized and excreted from your body, and so it's no longer present. So it's not like you're building up a storehouse of warfarin in your liver. Some of the vitamins, like vitamin B12 and vitamin D, you can build up stores. But with warfarin, you do not build up a store. So there is no concern for long-term use. Again, warfarin's been around since 1954. Patients have been on it many, many years without any evidence of liver damage.
Thank you.
Well, there's the salt itself doesn't affect warfarin, or the blood volume level usually does not affect your coagulation cascade. It in and of itself is not a trigger for clotting. It's a trigger for high blood pressure, which is another story. Well, those are two excellent questions, okay? And the first question is, whenever you're starting warfarin and have never been on warfarin and we don't know what personal dose you need, we often need to test once or twice a week to make sure we sort of find the right dose and fine-tune it. One thing I didn't mention earlier in Dr. Sasahara's question is that one of the best things that we do for warfarin use is to actually have dedicated anticoagulation management services with people skilled in knowing when to test patients and knowing when to adjust the dose of warfarin. So once you're past the initial phase of testing to find the right dose, we still require testing, but not as frequently. So I don't want to give you the idea that once you're on a dose and you've been okay for a few weeks or a few months that you never need to be tested again. We certainly know that the more frequently you get tested, the less variation or less big swings you have in your INR. So the more stable you are, because we're testing frequently and making smaller adjustments. There are some new anticoagulation guidelines put out by the American College of Chest Physicians that just came out in February that actually have suggested that in some patients it's actually okay, once on a stable dose, to check every 12 weeks. Now, most of us in the United States check people once a month. And again, it's because there are sometimes changes in your body, lifestyle, diet that you may not be aware that impact your coagulation level and your warfarin dose. Sometimes something not as obvious as switching brands of warfarin can affect your dose. So we prefer to test. So you will still require testing. Your second question, how long do you need to be on anticoagulation? It should be addressed to your care team, your physicians, nurse practitioners, pharmacists. The duration that you're on anticoagulation depends on the reason why you're on it in the first place. Whether it's a blood clot after having surgery, whether it's atrial fibrillation that's persistent, whether you have a mechanical valve, lots of different reasons, lots of different lengths or duration of anticoagulation, very patient specific.